If not, let's move to our third presenter, Dr. Stephen R. Goldring, MD, the Richard L. Minshall Research Chair of the Hospital for Special Surgery in New York and a former professor of medicine at Harvard Medical School. Dr. Goldring will speak on targeting disease.
So I would also like to thank Professor Moore for organizing this meeting and for his efforts to bring these very important issues into the presidential debate. So my goal will be to discuss healthcare issues and to highlight the importance and impact of medical illnesses on the American public and to ensure that these issues become part of the ongoing presidential debate. Healthcare costs and their impact on the economy have clearly been within the public eye. And I think this is for obvious reasons. Data from the Center for Disease Control reveals that close to $3 trillion are spent per year on healthcare. This presently represents 16% of the GDP. And if we project ahead to the year 2021, without some modification in the present sort of model, it's predicted to be 20% of the GDP. So to date, the healthcare debate has focused primarily on the costs of the services and issues surrounding access to care. These are what I would define as systems issues and clearly need to be at the center of the debate. And they will continue to drive the debate. But as we struggle with these challenging issues, are there other opportunities to address the challenges of the escalating costs? What would be truly transformative would be the development of new treatments and new therapies that could cure or prevent those illnesses that are responsible for generating the costs. Discoveries of cures and treatments can only come from research. Research that defines disease mechanisms, that identifies treatment targets, and develops and generates new drugs that can prevent these diseases. Medical research offers the promise for cures and treatments that would change the equation of the healthcare cost debate, and most importantly, would reduce the burden of pain and disability on the public. So are there compelling evidences that research can impact and change the equation of healthcare? And I'll offer several examples for you. And the first is the elucidation of the role of cholesterol in the pathogenesis of cardiovascular disease. And the discovery of the statins, drugs that control cholesterol, and the introduction of statins that have had a profound effect on the incidence, complications, and costs of heart attack and stroke. The second example is the discovery of the so-called HER2 gene and its role in the pathogenesis of breast cancer. And this has been enabled by the advances in the technologies of molecular biology that identified the critical role of this gene in generating risk for breast cancer in women carrying that particular gene. The discovery of the gene led to the rapid identification of therapeutics that target that gene, and now women with a simple diagnostic test can be identified as potential carriers and specific therapies initiated that have changed dramatically the outcome, the costs, and the care for these individuals. Data from the Human Genome Project, another major research initiative, has identified additional genes that are causative in cancer. And this is profoundly affecting now the approach to cancer therapy and treatment. And then finally, in my own field, the discovery of the protein tumor necrosis factor. This is the protein that drives the inflammation and the joint destruction in rheumatoid arthritis and the inflammation and damage that occurs in patients with inflammatory bowel disease. The discovery of this protein led to the development of powerful and specific so-called biologic therapies that can now slow and arrest the progressive debility that individuals with these diseases would otherwise experience. So it is clear, and there are many, many more examples, that the savings to the government and society that result from these research discoveries far, far exceed the actual costs of the research that led to their discovery. The healthcare debate needs to be expanded from the single focus on costs and access to care, not because they are not critical issues, but needs to include strategies with the potential to cure or prevent the diseases that are responsible for generating these healthcare costs. This is particularly true for those diseases that affect a substantial percentage of the population, where the total costs of caring for those individuals is high, and where new biologic medical knowledge offers the promise for reducing disease burden and cost. Each year, the major chronic diseases such as heart disease, stroke, cancer, diabetes, and arthritis account for 75% of that close to $3 trillion that we spend on healthcare. Improved therapies and treatments for these conditions would dramatically change the healthcare cost equation and should be part of the healthcare debate. As part of the need to expand our research for targeting disease, my goal is to inform you about musculoskeletal conditions, which to date have received little attention in the healthcare debate. I've selected these conditions for several reasons. Firstly, as I'll point out, they affect a huge segment of our population. Second, they are the most common and major cause of disability among adults, especially working adults, and therefore place a huge burden, financial burden, on our society. And then finally, support for research to cure and prevent these diseases is substantially underfunded relative to other medical illnesses and conditions. So I want to stress that this is not to suggest that in allocating support to musculoskeletal diseases that we should reallocate money away from the other major clinical conditions and diseases such as cancer and cardiovascular disease. But we need to broaden our commitment to targeting those diseases and conditions that are the top causes of disability. And it is for this reason that I've chosen to focus on musculoskeletal disease. So let me provide some of the background information that has helped us to understand the impact of these conditions. In the 1990s, the World Bank commissioned the first global burden of disease study, which resulted in the assessment of disease burden for over 100 diseases and injuries, including musculoskeletal diseases. Musculoskeletal conditions include a diverse group of disorders that affect the bones, the joints, tendons, ligaments, and muscles, and encompass a broad spectrum of conditions from those of acute onset and short duration, such as those associated with injury or overuse, to chronic disorders. So from this study, 5 major musculoskeletal conditions were studied in detail, and they included osteoarthritis, rheumatoid arthritis, gout, head and neck pain. And they also collected data from other musculoskeletal conditions, including autoimmune and inflammatory diseases such as rheumatoid arthritis and systemic lupus. In the US, studies show that musculoskeletal conditions are responsible for more functional limitation than any other group of medical conditions, and they are the major cause of lives lived with disability, duplicating exactly the findings and conclusions from the World Bank study on global health. More recently, in 2010 through 2012, the CDC, Center for Disease Control, analyzed data from the National Health Interview Survey, which revealed that over 50 million adults in the US experience joint symptoms. And of these, over 20 million reported arthritis attributable activity limitation. With the aging of the U.S. population, the prevalence of arthritis will inevitably increase, so that by the year 2030, an estimated 60 million adults will have doctor-diagnosed arthritis. So let me provide just a brief background on some of these conditions and their impact, economic and personal impact. So osteoarthritis is by far the most common form of arthritis and accounts for a majority of the patient and physician-reported causes of arthritis. It's characterized by damage to the joint cartilage and to the bone around the joint that ultimately leads to loss of function and progressive disability. Joint replacement, the ability to replace damaged joints, has revolutionized the treatment of patients with end-stage osteoarthritis and represents one of the true medical miracles of these past decades. But the projected increase in the number of individuals who will need joint replacement over the next 10 years will place a huge financial burden on the healthcare system. The procedure itself markedly improves quality of life, returns people to full productivity, but the millions of people that will be coming of age and requiring these implants will nevertheless put an enormous burden, financial burden, on our society. And we need to discover and identify interventions that can slow or even halt the progression of this disease. To understand the impact of osteoarthritis, it's estimated that the societal cost in terms of lost days of work and medical care is over $60 billion per year. Better treatments could have a profound impact on these numbers in reducing the costs of care for patients with this condition. Rheumatoid arthritis and gout are inflammatory conditions that affect multiple joints and lead to acute and chronic inflammation and deformity. As I mentioned before, research that discovered tumor necrosis factor and the development of the biologic therapies have markedly improved the natural history and outcome in these patients. But to date, despite these treatments, over a third of the individuals with rheumatoid arthritis continue to experience symptoms and progressive loss of function. It's estimated that in terms of lost days of work and medical care for patients with rheumatoid arthritis, the numbers are close to $20 billion per year. And finally, osteoporosis. Osteoporosis is a systemic skeletal disorder. It's characterized by bone loss and deterioration in bone structure and strength. It's a major risk factor for fractures of the hip, spine, and wrist. Hip fractures are particularly debilitating and may be associated with close to 20% mortality and 50% permanent loss of function. Research in the area of bone diseases has led to the development of multiple drug therapies that can improve bone health and substantially reduce the risk of fracture. But additionally, there is a marked need for agents that can actually increase bone mass rather than just halt bone loss. The use or the development of so-called anabolic agents. The cost for care of patients with osteoporosis and with fractures is close to $15 billion per year. So I've given you 3 examples among the many musculoskeletal disorders that illustrate the cost to society. If we take into account all of these conditions, the annual estimated direct and indirect costs are over $200 billion. The development of cures or effective treatments that could reduce the burden of these diseases, even if by 25 or 30%, would have a profound impact on healthcare costs. In spite of the widespread prevalence of musculoskeletal conditions, they're not among the top 10 health conditions receiving medical funding. Funding remains substantially below that of other major healthcare conditions such as cancer, respiratory, and cardiovascular disease. The National Institutes of Arthritis, Musculoskeletal, and Skin Disease was formed in 1987. It's the principal NIH institute that provides extramural financial support for musculoskeletal research. Presently, NIAMS receives less than 2% of the annual NIH budget. In March 2002, President George W. Bush proclaimed the years 2002 through 11 as the United States Bone and Joint Decade, providing national recognition to the fact that these conditions are the leading cause of physical disability. At the end of the decade, the Bone and Joint Initiative was formed, and it conducted a strategic planning process that solicited input from a panel of experts in the fields of musculoskeletal research, education, and care to set priorities beyond the decade. So I've included this in my handout, and it's beyond the scope of what I want to say today to go into detail, but I'll just emphasize a few of the points from that study. The first is that there needs to be education of policymakers. They need to be aware of the personal and financial impact of musculoskeletal conditions and the need for increased funding for arthritis-related research. We need to train and recruit the next generation of scientists with interest and expertise in this area. And finally, research in this under-researched area needs to be increased so that the discrepancy between research funding and the prevalence of disease can be brought into line. It's this lack of funding and lack of research in this area that has profoundly impaired progress. There is also a need for more clinical research and innovative clinical trial design. We need to have improved diagnostic markers, and the process of drug approval needs to be accelerated by working more effectively with the regulatory agencies. So I'd like to describe two programs that provide examples of innovative approaches to research discovery that I think hold substantial promise to change the game with respect to these diseases. These programs have in part been enabled by the remarkable advances in technology in molecular medicine, genetics, and cell biology that can much more rapidly translate observations at the bedside to the bench. The first is the Precision Medicine Initiative that was created by the Obama administration, which was recently announced in a perspective in the New England Journal of Medicine by Francis Collin, the director of the NIH. And the program is based on the concept that the prevention and treatment strategies for diseases needs to take into account individual variability. The program provides $215 million, and it represents a cooperative effort by the NIH, the FDA, and the Office of Health Information. And the plan will be to utilize large-scale patient databases that have come from registries and mobile health technologies and contain clinical as well as genomic and proteomic data from huge patient cohorts, and to apply state-of-the-art computational tools to identify unique, individual, personal biomarkers of disease risk, to characterize disease mechanism in individuals, and then use this information to select specific and optimal targeted therapies to target the pathologic process in that individual. There is a near-term focus on cancer and a longer-term focus on major illnesses causing disability. By targeting disease mechanisms that are specific to a given individual, the expectation is that the drugs can be more effective, will have reduced toxicity, and importantly, have better chance of cure. This ultimately has the potential to hugely reduce the burden of disease, but importantly, the cost to society. If we go back to the example of the discovery of the HER2 gene and its implications with respect to breast cancer risk, individuals carrying this gene can now be treated with a specific therapy that blocks the activity of that abnormal gene. They don't need to go to the extensive chemotherapy and radiation therapy because it's possible now to use very specific therapies. And in this area, there are multiple examples now, particularly in the field of cancer, of the success of this so-called precision, individualized, personalized medicine approach. The second program I'd like to discuss is the so-called Accelerating Medicine Partnerships. It's a public-private partnership between the NIH, the FDA, 10 pharmaceutical companies, nonprofit organizations, and 10 major academic clinical centers to transform the current model for developing diagnostics and treatments by jointly identifying and validating promising therapeutic targets, working together. It's funded by $230 million, and it focuses on 3 major medical conditions: autoimmune diseases, rheumatoid arthritis, and lupus. The second is type 2 diabetes, and the third's Alzheimer's disease. And the goal, similar to the Precision Medicine Initiative, will utilize large-scale patient databases available from these 10 major medical centers to identify unique disease markers of risk and define disease mechanism. This information then will be analyzed and shared with the partners in the pharmaceutical industry with the goal of accelerating translation of findings into more rapid drug discovery. So before closing, I want to discuss the issues of what are the risks if we don't take this approach, if we don't change the focus of the healthcare or expand the focus of the healthcare debate to include the importance and impact of enhancing research to target diseases that affect the American population. The first is that the costs will continue to rise unless we can find more effective therapies to prevent and treat these conditions. We will miss the opportunity to reduce the burden of disease, which are the main causes of disability. And the last point, which perhaps is not so obvious, but in fact may be the most critical point, and that is that if we don't invest in research and in our scientists and in our pipeline of trainees, we will not achieve our goal of finding near cures and treatments. So here are some sobering data from the National Institutes of Health. The NIH is the largest source of funding for biomedical and behavioral research in the world, with a total budget of approximately $30 billion. Over the past 10 years, the total funding for the NIH has effectively lost 22% of its capacity to fund research. This is due to budget cuts, sequestration, and inflationary losses. During that same period of time, China has increased its research funding by 13% per year. These are data from the Federation of American Societies of Experimental Biology. Although there's been a steady increase in the numbers of submitted research grants over the past 10 years, the percent of funded proposals to senior scientists has steadily declined. Presently, less than 15% of grants from established productive investigators are funded, and many established productive laboratories have had to close. The average age at which a scientist receives their first major independent grant is close to 45. The result, and I can attest to this, is that fewer and fewer of our brightest students are electing not to pursue careers in research. So in closing, I hope I've provided information that informs you of the importance and impact of the burden and cost of medical disease, and hope that I've convinced you that the topic of targeting diseases needs to be part of the ongoing presidential debate related to healthcare issues. I chose to focus on musculoskeletal diseases, but provided many additional examples, including cancer and cardiovascular disease, for which discovery of new treatments hold the promise to markedly affect the healthcare cost equation. Thank you very much.
Dr. Goldring, thank you very much. Are there any questions for Dr. Goldring? Thank you very much then, Doctor. Appreciate it.